Well, going to start this session. I'm Ruben Quiros. I'm a pediatric gastroenterologist specialized in liver. I worked with Alagille early on in my career, and since then I have special interest in Alagille syndrome. Obviously, I don't do as much research as I used to do, but still very active with the Alagille Alliance. I'm part of the medical board and so forth. And today, I'm going to talk to you guys about diversion, which is a type of surgery that you have heard a little bit this morning, and also liver transplant as well. How many of you have kids with liver transplant already done or post-transplant? Okay, we have 3 or 4. How many have kids in the liver transplant list or are waiting for transplant? How many of you have been told that your kid may need a transplant at some point? Okay, I guess that's the larger group probably have interest on this. Then my intention is not to come here and give you a long lecture about liver transplant and how you do diversions and all those things. It's more to have something interactive. I also want to do things or talk about things that will be pertinent to you guys, because that's the main objective I have in this talk is, as I say, not to tell you all what I do, is more to what the things that I know, how those things can help you to make things better, improve decision-making process and things like that, and obviously try to answer some questions, because surgery obviously all the time, I'm not a surgeon, but I work close to them, and it's always something that comes as something aggressive that is going to be done to your child, and obviously that entitles a lot of different factors involved in it. Then the first part I'm going to talk a little bit about is the diversion as a procedure, and this morning you heard a lot about it, about pruritus, itching, and all those different things, what could be the indication for that, and I will cover some of that. But again, as I'm going through this, is when I also explain a little bit more of the rationale behind it, of doing that. Then this slide, this is one of the papers I worked on early on in my career, but you can see here the incidence of, in this series, the incidence of pruritus or itching is really high. This almost 9 out of 10 people with Alagille syndrome are going to complain of itching in some point, and different degrees of itching. And this is another thing that Dr. Piccoli talked about this morning about St. Thomas. It is very related to how your cholesterol is in the blood, and obviously also very much related to the degree of cholestasis. And we tend to see it early on more in life, like 3, 5 years, the school age, or more or less. And then also all of a sudden, some of these patients get better, but some of them remains with this. And as Dr. Piccoli says, it's a function of the cholesterol in the blood. Now, we will not do a diversion just for that, but that could be an indication sometimes, at least a consideration if other things fail. But I think the main indication for the diversion will be the itching, the pruritus that we call. That would be too bad. Then this is not by any means what was mentioned this morning about the score for pruritus. Now we have a much different score, because if you look at this is one that was used by Peter Whittington, back in 1988, just to scale, in some way, to try to give some objectivity to something that is subjective. That was the initial attempt. Right now, there's a much better survey with Lumina has, basically with the new trials, that's going to be a little bit more sensitive on changes. Because if you look at this scale, 0 is none, this 1 is rubbing or mild scratching when undistracted, active scratching without evidence of skin abrasion. Then from 0 to 2, usually we'll call it mild, moderate at the most, obviously, if you interfere with sleep, even though if you don't scratch yourself to the point that you start having damage to your skin, then we won't call it necessarily mild. It will be more moderate, because if you cannot sleep, it's interfering with your sleep. Abrasions, evidence is when now you start causing problems in the skin integrity is lost, And as Dr. Piccoli mentioned this morning, that unfortunately worsens things around. And 4, obviously, is the more severe one. And there's actually scars and everything involved. And those are the cases that we usually we will probably consider diversion if all medical treatment has failed at more or less at this level, generally speaking. But doesn't mean necessarily you have to wait until then. These are some of the medications, the list of them that Dr. Piccoli in his talk about. And I'm not going to spend a lot of time on this, but obviously, probably this will be the more benign. This one, we don't know the mechanism for some reason help, and you saw it this morning, like about half and a half or 60-40. But these are things that we usually try first. Phenobarbital and Tegretol, those are medications that don't necessarily used a great deal, but those are mentioned. Still, there are some colleagues that use it. But I think this has too much side effects for my taste. And then cholestyramine is a bile acid binder that could be used sometimes to help because it will decrease cholesterol. It decreases the amount of bile acids in your blood. But like any binder sometimes, it's not as effective and actually may interfere with absorption of some other vitamins that are crucial for your body, like fat-soluble vitamins A, D, E, and K. Then the external diversion, we call it PEBD, and we talk a little bit about this. And I have someone here that later on is going to volunteer. She'll come later to show us a little bit of this. But what it does, basically, when you get to a point that scratching is so bad that, as we described, then you may want to consider this if all the medications that you can try has failed. As we say, it's a hit and miss. Sometimes medication may work, and that's good. But sometimes that medication stops working, you try a different one, and you go back and forth to these different things. Obviously, the itching can be controlled in different ways. Environmental things are important, but that was already covered in the talk. But basically, and I will show you in a graphic, what you get to drain is about 1 to about 4 ounces of bile every day. And basically what you do, just to remind you, this is a normal anatomy. This is the liver, gallbladder, and this is what we call common bile duct that end draining here in the duodenum, which is the very first part of the small bowel. This is your food pipe, where food comes down to the stomach, and the stomach goes out. And this is where the food is going to meet all the secretions from the pancreas and from the liver, right here. In the second portion that we say that the ampulla is there, that's when the bile drains. Then what you want to do in this kind of procedure is basically have the bile bypass the terminal ileum. As you saw, you remember the talk this morning was there is a cycle, we call it the enterohepatic circulation, where the bile acid reach the end of the small bowel, which is called terminal ileum, and then gets reabsorbed. What you want is that when things do not get reabsorbed, then your liver has to produce some of that, but some of that is lost. Then there's it's a little complex process. There's also secondary bile acids that happens in the intestine, but all that is affected in a way that is positive, actually, for the things that may have to do with itching, usually in relation to cholestasis. Then what you do is you take a piece, this beyond the duodenum, this second part of the small bowel is called jejunum. Then you take a piece of jejunum, usually about 10 centimeters, keep all the blood flow, and that piece of jejunum, you're going to join that to the gallbladder, and the gallbladder is going to drain outside. And then you can drain that. And then you reanastomose or rejoin whatever, from here, let's say from here to here, just to say something. Then you join that again. Then there's some, it's the major surgery if you think about it. Not that complicated, but obviously you have to open the abdomen and move things around a little bit. I won't spend a lot of time on this, but basically this is a paper out of Chicago that basically show improvement, how things improve. And then what they notice is that there's a good proportion of patients, not all, but good proportion of patients that the itching gets better, but not only that, but also the bile acids in the blood decrease, which kind of correlates with itching. And then also the cholesterol is kind of a secondary thing. But if you have someone that has itching and xanthomas, as we show, both of them are going to get better by doing this procedure because it's going to affect the cholesterol level as well. Again, I won't recommend that for a hypercholesterolemia, but it's a consideration sometimes when you have those deforming xanthomata. And I will show you. I also have a picture here. But basically, this works fairly in that I would say 2/3 to 3/4 of the patients. Obviously, as I say, we will consider people with severe pruritus without cirrhosis. Then why put that without cirrhosis? Because I think that if someone has severe pruritus and already has end-stage liver disease, that will be the second part of my talk, which is now you have to consider transplant because in a cirrhotic liver, you know the liver is already end stage. It's not going to get better. And eventually, that could be that combination could be an indication for transplant. But if there's fibrosis and no cirrhosis or evidence at least of portal hypertension, you could consider doing the diversion if there's not that. Okay, here. Then there's also something called the internal diversion or ileal exclusion. And basically, this shows a paper in 2007 that just have 3 cases. But basically what they do, just going back to this, is now you also kind of the same principle. The main principle, and also for medications that are being looked at, is that you don't want bile acid to get reabsorbed in this area right before the large bowel, which is called the terminal ileum. Then what you do is you bypass that area. You actually cut here and create an anastomosis downstream directly to the colon. And what this does is that bypasses this area where the bile acid is going to get reabsorbed. And then that also have the same impact, as we mentioned before, in your serum bile acids and on itching as well. And this is a patient that has itching and has this deforming xanthomatas, kid with Alagille Syndrome, and then basically how things got better. 8 months pause up, improve a little bit, and this is pretty much gone. And the only problem with these 2 procedures, and I will have Lena, you will at the end I will have her. She went through the procedure and she came here to share with us some of her experience. But we'll do it at the end, and that way we have more time to do it. Yeah, if you don't mind. But basically, the only main concern that you have with either procedure is in a kid that is already failing to thrive, because there may be some challenges when you do this in regard to nutrition. The main thing is, first, you can have fat malabsorption out of this because your bile is affected. That's one consideration. And the other thing that you could have is fat soluble vitamin deficiencies. Overall, the more important one would be vitamin D, which it has to do a lot with bone health. Then that's we heard a little bit of that talk again today as well. Those are considerations. Obviously, you have to put in balance all those different things. But when it works really well. Then quickly, I'm just going to go over the liver transplant a little bit, and then we'll have some time to answer some questions. Elena will show us how things are. All right. Then for the liver transplantation is something back in the day. This is a paper I work on. This is in 1999. That's about the time, 98, I think that's when the understanding of the genetic problem was brought up by Philadelphia. Then before that time, the diagnosis will be based upon what we call the 5 criteria that I'm sure you have heard about. Those 5 main things that you may find in Alagille syndrome that were described by Alagille, the French doctor, and when he described this problem for the first time. And this paper tends to overrepresent a little bit more severe cases, basically. I think as our understanding has come, we have learned a lot since those papers. And liver transplantation is we see it as something. Obviously, it's a treatment, but you are trading one problem for another one, which is now you have a liver transplant with immunosuppression, which is something I always make it very clear, because this is not just you got better and that's it. It's just you have another issue now. It's a chronic problem as well that you have to keep track of things and so forth. But the liver transplant, it was about 47% in the series, 21, 24. These were involved a little bit more milder cases. I think this is an overrepresentation. I don't think that many patients need transplant nowadays. I would say it probably lands around 15 to 20. 1 out of 5, 1 out of 6 patients may require transplant during their lifespan. Then we don't want to transplant every patient that have a liver disease. Obviously, there are certain indications for that, and you have to reach them because, again, you always want to outweigh risk and benefit. You really want to see the benefit of doing it, and really outweigh the risk of undertaking transplant. Then, since they are going to affect the survival overall, is pre-transplant nutrition, and I think nutrition is important for any surgery, and you have to secure as much as possible that the patients are growing, getting all the nutrition they need, and you have to be as aggressive as you can. How sick the patient was before transplant. Indications for transplant, this is, in this case will be Alagille Cholestasis. It's different, that is a fulminant. Fulminant failure will be someone that is a kid that is healthy and then also in developed liver failure. The liver stopped working all of a sudden. Then there are differences because this could be somehow planned or you set up a time a little bit when you want to do it. Previous abdominal surgeries may affect the overall outcome. The second transplant or having to do a second or third transplant, obviously, that will impact outcome. If there's any problems outside the liver, for Alagille syndrome, always it's important to understand, your outcome is going to depend upon a lot of other problems, like there's heart disease or there is kidney disease. Those things are things that we really need to understand to improve the outcome as much as possible. And if you are older than 1 year, it tends to be better outcome because of the the type of surgery you have. You kind of sewed like 2 little vessels, like just to give an idea, the hepatic artery, the lumen, the little space where the blood goes through, it may be 1 millimeter or 2 millimeter in someone that is younger than a year, probably 1 millimeter. Then doing that stitches around is more difficult than if you have someone that has 3 millimeters or 5 millimeters if it's older patient. This is just to go over quickly different techniques. Split is when you take a liver and divide it in 2, and I will talk a little bit about it. Reduce is when you take part of the liver and the other one you don't use it. And living donor is something that always is a possibility as well. Quickly, I won't try to make this an anatomy class or anything like that. Don't worry. But basically, just to give you a rough idea, why someone could donate a liver is because the whole liver is about 2% of your weight. And if you keep a ratio of at least 0.8% of your weight, you do not get in trouble. Meaning that if someone by any means lost part of the liver, not necessarily is a life-threatening event. And that's what allowed you to do surgeries in the liver sometimes. Someone have a tumor in the liver, and you have it in this segment, you can just resect this segment. Or you have it in these 2 segments, you just resect those 2 segments. And you are left with about 60% here is about, there's about 50, 60% of your liver, more or less, 60, 70% of your liver. Now, for transplant, when you talk about split, what that means is that you can have this part for one patient and this other part for another patient. Then you get a donor, it's a cadaveric donor. Then you get the liver, you split. And then keep in mind the proportion I just talked about, 0.8%. Then if this mass is at least 0.8% for a patient, if the patient is small, the bigger the person, the bigger is the liver. Then this part could be placed in a child safely. And then that person can have a normal liver function in the future. The beauty of the liver is they have the ability to regenerate. I don't know if you have heard that concept, that the liver regenerate. What that means is like, by any chance someone loses this segment 2 and 3, this part of the liver, then this rest of the liver is not going to look the same ever, but this will enlarge to a point that the mass of the liver comes back to be the normal, the same one. Keep in mind the same proportion, 2% of your liver. Then the liver have the ability to do that. Then if I put this in a 2-year-old, for instance, this segment 2 and 3 can go all the way through adulthood, undergoing changes in the mass without needing to do another transplant, because that's part of the ability, one of the quality of the liver is to have that ability. Then when we do liver-related, usually for a kid, if you do a liver-related, will be this segment 2 and 3 usually. Again, you don't want to put either a liver that is too big. What I mean through that is you don't want to put 3% of the weight of someone, or 4% of the liver weights, 4% of that patient's weight. That's too much. That's too big. You cannot close the abdomen. Then you cannot push it. Now sometimes you can put a 2.5%. But interestingly enough is that if you put a 2.5% weight liver, weighing 2.5% of the weight of the patient or the kid, actually now the liver is going to shrink down a little bit to now keep that proportion, okay? Then that's an interesting fact for the liver, because those are questions come across fairly frequently, is that if you just get these 2 segments here, for instance, what will happen? Do you have to retransplant? Because when someone starts growing too big, then this is not enough. And the answer is no, you don't have to retransplant that person. I have known patients that have been transplanted in the 80s, late 80s, that's when we were doing in Los Angeles, and now those patients, actually, one is a female, she already had a child, and she got a segment, what we call a segmental transplant. Then, just to talk a little bit about that. Here. Then in Alagille syndrome, you always have to keep in mind, well, this is a genetic disorder. Can I be, when you talk about living related, can I donate part of my liver to the child? And I think, to your child. And I think you could consider that, because it's only about 4 out of 10 parents that are going to have paucity, which is actual liver disease. When you work someone as a donor to be a potential donor, a living related, what we call living related, or living donor, more than living related, because we used to call it living related because usually the person will come up front and say, I want to donate, will be a relative, but that we don't see that anymore. We are now seeing people that are not related coming forward and offering to donate. But then what you need to do is you do tests. You want to understand let me go back. You want to understand that anatomy I talk up to you about. You do MRIs, you do sophisticated X-ray in the donor to see, okay, does this look like it's going to be an easy to kind of resect surgery to put it in a patient, taking away for a child segment 2 and 3. Now, in adults, also they have done living donors, and they have used this part now here, which have more challenges. Then if the older the patient, it's not like you cannot donate to an adult, but that probably involves more risk for the donor as things are of today, because this, you gotta take a different part of the liver. Now, okay, then once you also do a liver biopsy in that person to try to understand if the person the donor has liver disease, as I say, paucity. And I mentioned here segment 2 to 3 are usually. Then this is what you usually, this is from a paper out of UCLA, but this is usually what you do in a living related. You take segment 2 and 3 for a child, obviously keeping in mind the proportion I talked to you about. Then you cannot do this for an 18-year-old or a 45-kilo person, obviously. Then in that person, you have to consider then using some other segments of the liver. But this is technically a little bit easier, and there's less risk for the donor, truly, than the other one. Doesn't mean that this cannot be accomplished, the other one. And this is the way it will look in the person once you put back the liver. And as I say, that liver is going to look in mass. The mass is going to get. The shape is going to be all different than the normal shape of the liver. But the liver, when you weigh, by any chance you had the chance to weigh that, is going to get bigger. Then ethical things that you have, obviously for liver-related, in any program you have to have two separate teams, one that evaluates the donor and one that does the transplant, because there's an ethical conflict of interest. I should not be giving advice to someone that comes forward and want to be a donor. Got to be a different team, because that person, if sometimes there can be pressure from the family and so forth, and always they have to have a way out, and you because sometimes people are scared, or there's a value. Sometimes kids, you have one parent, then you don't want to put that parent, if they have other kids, through the risk of transplant. Then you have to keep in mind donor safety, psychosocial evaluation. Obviously, sometimes you find that the person is depressed or have some psychological problem or issue. You don't want to put that person through a major surgery. Then that takes a whole process to really evaluate. Really, the person needs to understand the risk. What are you going to go through, the potential complications from it, because all these are surgery. These are people that are healthy to coming forward and want to donate a liver. Then you want everybody to walk out of the hospital in good shape. And then there's also tests. It sometimes include even a liver biopsy. The reduce, I won't spend a lot of time on that, but that basically means that, for instance, I got a cadaveric liver or donor that disease. Then I just take part of the liver, and then the other part, I don't use it. I just send it away. Then that one has the disadvantage. It's not as encouraging, because you could be using that other part for another recipient. When to do a liver transplant, I think when you have a lot of itching going on sometimes, when in front of cirrhosis, as I say, no, if someone that has a normal liver, or even if has some fibrosis, not necessarily cirrhosis, I think you can do some other things. It's not an indication. But if they have failed to try malnutrition, and this has to be taking into consideration also that the fact that Alagille syndrome, from the genetic standpoint also, sometimes there's issues with how high the kid is, or failing to, what we call failure to thrive, which truly probably is okay because of the baseline disease. Portal hypertension, this is all in relation to end-stage liver disease. This is also in relation to ascites, when you get fluid in your abdomen inside, in the peritoneum inside, there's fluid. There's all this are complications from what we call end-stage liver disease. Your liver will not be able to recover from the damage. That's when that's what we call cirrhosis. There's so much scars in the liver that now you cannot reverse. The interesting thing with the liver also, I didn't mention this, as in the same way it has the ability to regenerate. If you improve the problems that is leading to fibrosis, sometimes you can have reverse. The fibrosis can reverse. The scars can go away a little bit, and that can happen sometimes. In some patients, I haven't seen as much in allergies, but it can happen if the cholestasis start improving. You have a lot of bile toxicity from the bile being there. Sometimes your fibrosis can stabilize or doesn't progress. And unacceptable quality of life, those are things that obviously is a relative indication. Those are things you have to sit down and figure out what the problems are. Are these caused by end-stage liver disease? Usually, you will never do a liver transplant. Oh, well, I shouldn't say never, but most of the time, you want to have that end-stage liver disease to suggest that the patient needs to be transplanted. Then that's what we call the cirrhosis. This is just to point out, this is a study I did back in UCLA, but kids with allergies tend to have this -2, all this is below the normal curve. Everybody, even if they don't have transplant, if you take a group of kids and plot them, they are all going to be pretty much on the lower end of the growth chart. But this is what happened with the kids that have more problems. Usually they are going to be farther out. Then when you evaluate failure to thrive in allergies, you have to be careful, because the genetic defect and other problems, pancreatic insufficiency, some other problems, can lead to failure to thrive. Not necessarily that the liver is really bad. It could be also heart disease, how severe the heart disease is, or renal disease as well. Then you have to put everything in context. This is quickly ought to tell you about the PEL for you. The ones that have had a kid undergoing transplant, you know this is a score that you get through different values. Bilirubin, this is a formula. And then at the end, you get a number. It can be negative, it can be positive. Usually it gotta be in the early teens or double digits at least to get an offer. But then you have the bile, the INR is a reflection of the liver function. Albumin is something that is could be part of liver disease or also part of malnutrition problems as well. And then if the kid is less than 1 year, gets extra points, or if the kid is having failing to thrive. So overall for the high, it's below the 2 standard deviation. Then we have to anticipate complications always. We continue, even if the patient is on the list, you want to continue immunizations as much as possible. If you get a live immunization, they won't be transplanted probably for 6 weeks because of the risk. But you want to keep on with the immunization as much as possible while you're when the patient is. Optimize nutrition, treat any complications, and which is also, this is an infection that happens sometimes. We call it bacterial peritonitis. If the kid has fluid that is being accumulated in the belly, that fluid can get infected. And that's something we have to keep in mind. Okay, let's see. Kind of froze. Okay. Long-term challenge is, for any of you that have experience of transplant, you know that there's a lot of medications that have to be taken at least over the first 3 or 6 months. The list is about 10, 12 medications depending upon the complication. But then at the end, what you hope for is that you just need, for the transplant end, just the immunosuppressor. That will be your ultimate goal. But sometimes you have to have some supplementations with vitamins and some other things. Then what you want to try to do is minimize steroids, because this bone disease is something in Alagille that is already a problem. Then your long-term use of steroids is going to affect your bone health. Then this is something you have to keep in mind. You want to be aggressive about sparing someone from steroids. Sometimes you can do it, sometimes you can't. You don't want to under-immunosuppress or over-immunosuppress, because that obviously has the problem. Remain with the therapy. I think sometimes as you hit the teens, adolescence is a hard time. Kids tend to stop taking their medication. Sometimes that's something we have always to keep on working on as a team. Monitor levels, keep on doing labs, acute and chronic rejection, you see, and then potential for malignancy. There's always a potential for what we call PTLD, which sometimes can be treated easily, but sometimes can be a little bit more complicated, because it can be basically behave as a lymphoma, which is a cancer basically. And that's a risk that you will have when you are on these immunosuppressors, the combinations of the EBV infection and the immunosuppression. Then, as I was saying at the very beginning, this is not to take lightly. I mean, we don't rush into advising transplant unless really is the main, as I say, the benefit. You can see clearly the benefit. Your likelihood of having your child with you in 5 years is much better if you transplant that patient than if you don't. Well, I'm almost at it. Doesn't move sometimes. Getting tired. Computer's not working. All right. Well, in any rate, I think that obviously to finalize, these are all these different things you have to watch for: the kidneys, neurotoxicity, hypertension, cholesterol again can be a problem with immunosuppression, and I talk about malignancy as well. Then physical appearance is something important, more so in the past. Psychosocial adjustment, growth and development, prevention of infection, and keep on with immunosuppression also. Some centers do not recommend to do live immunization, like the MMR, the measles immunization, or chicken pox. Then we try to do them before. Some other centers that have done it, and they haven't got into any major problems. We right now do it, but careful monitor the patient after this. We try to be at a time that immune suppression has decreased significantly. The period, unless there's complications like rejection, but if things work in the way we are expecting, the period of time that is higher risk because of the degree of immune suppression we use will be the first 6 months. Later on, if you haven't had rejection, steroid has been weaned off and all those things, then your risk of infections and complications start going down as you immunosuppress less. Okay, well, I just want to show you a picture if the computer let me. All right, that's it. Okay, this is just the overall survival for all comers. Is about 85%. Then this is 3 years, and it's about 85%, 10 years. Then you transplant 100 patients, 85 will make it 10 years after. Then again, there's not a it's not a benign procedure. Obviously, there are some other reasons, and I think for Alagille syndrome, it's close to this, a little bit lower, but it's a function also sometimes if there's any other comorbidity, what we call comorbidity. If there's a renal disease, how severe the heart disease is. Some kids has undergone double combined transplant, heart and liver, and there have been cases of triple transplant, heart, lung, and liver. There have been cases like that, just because of the severity of the heart disease, the heart condition. And you heard a little bit about, you know probably about all these possible, problems in the heart. And the most common one is the one that happened in the pulmonary artery that gets a little narrowed down. We call stenosis, peripheral pulmonary stenosis. And does someone know what that country is or place by any chance? Huh? South? Seattle. Looks like Seattle, huh? That's where I'm from. That's Panama City. Panama, yeah. Yeah, that's how big. Yeah, this is actually the canal comes here. The ships are, yeah, the Panama Canal is here, and this is the other side, and this is the Panama Bay. Yeah, nice place to go if you are planning vacation. I don't have any tourists. In any rate, I don't know if you want to talk a little bit about your experience. Yeah. You know Alina, probably, no? She want to share with us a little bit about her experience with the diversion. I don't know if anyone have a kid with a diversion done, or, yeah. Did that work okay, or? The internal, yeah. That's the one that we have some experience with. I have some experience with the internal. Okay, go ahead.
Okay, I've had, probably one of the longest that I've had an external. I've had it since I was 12, so it's been about 12 years, almost 24. We had it done in Chicago, and I was actually, I know Ruben showed the Chicago study done by Karen Emmerich, and I actually—
You're one of them?
Up there somewhere. My numbers are there somewhere. But yeah, I was part of one of the studies that she did back in 2002 for that, and that was why we had it done into the study, and then what it involved. And I started, I guess, kind of a little bit of background. I started itching at about 2.5, and up until the surgery, wasn't responding to medication. Just had, terrible times on surgery in school, had scabs all over me, and just wasn't very fun. So they said, try this, and I said, sure, we'll go for a plan. It was major surgery at 11 years old. But I stopped itching in recovery after the external. My surgeon came out and said, she's doing an office, I said, not itching. And he looked at her and like, can't happen fast. She's like, you want to wake her up and ask her? But I stopped itching almost immediately. I still don't itch. I itch a little bit more than I did initially following the surgery now, but nowhere near what I was at. And a lot of it has to do with the environment that I'm in. Heat and stress tend to aggravate it. My feet tend to itch more than anything else just because it's long all the time. You get a lot of circulation down there and stuff. But I love having it. I don't I give a talk similar to this. I've done it last 3 years in my college class. So.
And what Lynn is saying is true. I mean, before the diversion, some kids 10, 15 years ago have received a transplant based upon how bad the itching was. When you had a severe itch and you went through all those medications, I mentioned, and none of them impacted the itching. Then I remember transplanting at least 1 or 2 kids out of that series that did not have cirrhosis. They have advanced fibrosis, they have scars, and may have been that eventually they will have required transplant. But those were things that were not available 15 years ago. And we start looking into this procedure more and more later. Yeah.
Question that I have is that why do you want to buy that time? Why, if the eventuality is that you are going to get a liver transplant, why not get it earlier? Because supposedly you'll get a little bit better growth.
I know in my case it was because when I had it at 11, they were saying, no, you're not going to need a transplant. Up until very recently, it was a question of if I would need a liver transplant, not when. And it's just kind of, as I've gotten older, my case of Alagille has taken the progression of, no, we're going to lean you towards a transplant. But yeah, for me, it was more about the quality of life and getting rid of the itching so that I could actually, go to school and pay attention and, be able to go out with my friends and have a better quality of life. And as a result of the stoma, I did grow. I did gain a little bit of weight. I went, leading up to it, I'd been about 4'7" and 64 pounds, give or take, for about 2.5, 3 years. And within a year to a year and a half of me getting the stoma, I grew several inches. I gained weight. I'm now roughly 5'6" and 125 pounds. And we never thought I was going to get that tall. And so for me, it wasn't that we wanted to buy the time. That was kind of a perk that we've now realized. But it was essentially the quality of life and the fact that I had been itching for 9 years. I was sick of it. I was just like, anything to get this to go away, I will do.
And from my end will be pretty much close to her answer. I think in general, that's what I point out, that you want someone to have cirrhosis to suggest transplant as much as possible. Then there's no hope for reversibility. There's no hope for improvement. I've seen, I don't have a lot of experience with diversion as patients that have full. Honestly, I have like 2 or 3 patients that I know closely, and none of them has been transplanted. I don't know if it will happen when they turn 24, but I will tell you that from that series, when you talk to the Chicago folks, not all of them has been transplanted. Then I think if you can avoid the transplant, you will be better off than having a transplant. I mean, obviously your native liver. Obviously, you put in context other things. I mean, you point out, like, what about your child is not growing? What about some other issues going on in a particular case? Then I will say, yes, you gotta analyze each case on his own. But if it's the main indication is going to be itching, because you cannot live with that degree of problem, that is not letting you sleep all day long, you scratching your skin, damaging your skin, and all those different things. That's the only reason, not having grow issues, not having other problems, no other complications. You don't have cirrhosis. I think I will suggest, and eventually we may have medications that will do that, like we were talking this morning. Then it's surgery probably better because, as we mentioned, that was mentioned also this morning, once you do the liver transplant, that's it. But if you do this surgery first, if the liver is not completely damaged, then you have the possibility that you may not require transplant at all. That's that possibility. If you have that possibility, that's when I would advise to do the surgery. But if you already have cirrhosis and some other problems in relation to the liver disease, and itching is part of the problems, then I think in that context, probably you want to do the transplant sooner rather than later.
Yeah, and I had no indication that we were ever going to need a transplant. I mean, the cirrhosis that has now set in my liver has been within the last maybe 3 years, 2 to 3 years. that they've said, okay, your levels are kind of starting to rise again, and you're progressively getting more jaundiced, and we're actually now seeing cirrhosis in your scan results. So, but we think that that may have happened sooner had I not had the diversion done. We think that that actually did buy a little bit of time. Yeah. Mm-hmm. Never happened. No, I mean I've heard that. I know in my experience it was I had itched starting around 2.5 up until I had the diversion done, and there was no indication that it was going to get any better. It had always been really bad. I mean, my mom, she remembers coming in when I first started. It was sudden and it was intense. I mean, she came in and I had literally scratched my legs raw overnight, and it was, and it never quit. I didn't, there wasn't any way for me to get any relief, and so I was one of those rare ones, I guess, that just, it did. As I got older, there wasn't any sign that it was gonna.
Yeah, and what happens sometimes is, like, in general, cholestasis gets worse, like, as was mentioned this morning, and then you get to a point that start improving some, and that's what you see in a large proportion of patients. And as the cholestasis get better, sometimes the itching also follows that. Then the itching improves a little bit. Then you find patients sometimes that had a lot of itching when they were 2 or 3 years old, but then all of a sudden when they are 7, 8, or 9, then the itching has improved. Now, as you see them, obviously this is a different degree, but if you have severe itching, as I was saying, the 3 and 4, remember those when you have people already marked, or even losing sleep throughout the night because nothing make it better. You try all these medications. I will say if the patient, that's the main issue with your child, you should consider this if you have not reached cirrhosis. If your liver does not have significant fibrosis or cirrhosis, I think this is something that you could consider, because at the end it's reversible in a way.
Mm-hmm.
Yeah, it's not a high. Yes, we are talking about severity of the itching, how the itching improve or doesn't improve throughout the years. And I'm sorry, yeah, yeah, and the itching seems to be getting worse, no? And what's the deal there? I think in those cases, I mean, if you have tried all these medications that we mentioned today, all these different environmental things, exactly, and you have a child that is causing harm to the skin, damage, clearly damaged, and not sleeping through the night, and you have tried all these different things, I think that would be a consideration. That would be a consideration to. Mm-hmm. Mm-hmm.
So that's when us as the parents get a little bit confused because we're hearing 2 different things from doctors.
Yeah. In general, I mean, again, if you have tried everything, I mean, obviously I don't have all those details of all the things that have been tried. But let's say all the medications that I mentioned, there sounds familiar to you, and some of the ones that Dr. Piccoli mentioned this morning sounds familiar to you, and all that has been tried. You have tried all the environmental things, as Dr. Piccoli talked this morning, on things that you can do. If your child does not have end-stage liver disease, does not have cirrhosis, I will say that you probably getting to a point that at least should be evaluated for a possible diversion as an option. You understand the risk of benefit, you talk to a surgeon, you know which one. The other thing you have to put in context is if there is any failing to try, severity of those things. But as Alina mentioned, I mean, sometimes just by taking away some of that bile acid, improve your liver disease. If you look at some of those biopsies that were shown this morning with the medication, you can see those changes also after the biliary diversion. Then my guess will be that probably she has more advanced liver disease at the time of the diversion, probably 9 years of that. But we don't really understand the impact that this can be. This may have bought her more time, as you say, rather than if she didn't have the diversion, probably 3 years later, by 12 or 15, she would have been transplanted. Now she's 24. Then that's time that you bought, and then it didn't affect her growth. Actually, affected in a positive way, it sounds like. And that's what sometimes you see that. Then I think sometimes it's you know, the not being familiar with the possibility of having a diversion. I think obviously not every center does that. There's a possibility just to look for a center that does it and see if you know, after looking at her, you know, if she's a candidate or not, or ask them if they do it there or not, or at least be considered for it. As I say, important is you have to see all the potential problems coming from liver disease. Then in a particular case, if the itching is the main thing and there's no cirrhosis, I think a surgical diversion is not that off. I think it's a true possibility that you should consider in someone with severe itching. No, I'm not talking about the kid that just, you know, sometimes the itching is not that bad. They just probably scratch when they are awake. They don't damage their skin. You put them on medication sometimes, rifampin or something, or urso makes things better, and then doesn't itch as much. And I mean, that's a different kind of a scenario where you are okay with the whole itching may not go away, but if you remain in a 1, for instance, of what I was describing, then probably you are okay. Why do you want to do a surgery? No? Right now, there's not a medication commercially available to treat. I mean, the other thing would be consider enrolling your child in one of these trials if you want. But I think you need to start looking into some other options. But I mean, at least have the evaluation in a place that does both, does the diversion and transplant, and then probably have a second opinion and see if it does make sense or not for your child.
Yeah.
Mm-hmm.
My doctor just told me that the itching and that could change when they go through puberty. I had never heard that before.
Get better or worse? As the kid age may get better. It may get better. It's not completely inaccurate. I will say I have seen it. I wouldn't. Sometimes I'm careful when I make those statements because then you have the child didn't improve or the child that all of a sudden worsened actually when time passed, because all is going to depend upon what is happening with the bile flow.
So you have the internal diversion,
Mm-hmm.
and then the itching returned by about 7 or 8. So
Mm-hmm.
you must have been before that, and then want to wait to do the external until they go through puberty, and I had never heard that before.
I need to go through puberty before transplant?
No, for the external diversion.
Go through puberty before the external diversion? No. For external diversion, I think, personally, at the end of the day, both are going to have the same risk, nutritional risk. Let's put it in that way. Then if you are not doing it, I mean, because obviously, having an ostomy in a child, but kids younger than 5 can sometimes have to do ostomy for some other reason. Then if you are thinking about the nutritional impact that this is going to have, what I mean through that is like, this may affect your ability to absorb fat, soluble vitamins, bone age, and all those different things may affect it. For the external, yeah, there may be some other, because I see the same risk personally, internal versus external, and actually the internal actually has probably more risk than the external from the surgical. I don't think someone has to go through puberty because you already have an internal, and then to have the external.
I guess my response to it too would be, I mean, I almost wonder, especially in my case, because I had mine so close to when I hit puberty. I had it at roughly 11, 12 years old, and then I, would have hit my growth spurt within the next couple of years, just kind of typically following what females usually go through with puberty. And, one thing my mom and I and my doctors have somewhat discussed, not really because we don't have a way to measure it, is, what if me getting it as when I did, the age that I did, that when I hit puberty, it was only a benefit. That's why we saw such an increase in growth and a dramatic weight gain, was because I hit puberty as right when I was, adjusting to this, and maybe the slight benefit you get in growth from the diversion was just compounded through puberty, because we don't know what, based on my growth chart when I was younger, they were saying, she's going to top out at 5'2", 5'3", and I come from a family where most people are 5'6" and taller, and so it was, we knew I was going to be really small and weigh significantly less than most of my family, but with the diversion, I now am right along there with them, and so part of it could be that puberty got a boost, or it was the diversion helped make that more apparent. So
now the thing with the diversion is not like cholecystectomy, or it's not a surgery that you do a lot, to put it that way. Then I think that's the main concern, but it's because there is a lot of uncertainty in in the nutritional impact. In the era that we're starting to do the diversion, the main concern was the opposite to what Alina is describing, is that you may cause fat malabsorption, you may cause fat soluble vitamin malabsorption. Then nutritionally, you may impact in your nutritional status in a negative way, because it will impact all your ability of the body to digest fat. And you see the opposite sometimes, and it could be a function of that the diversion may improve. If you saw some changes caused by the chemical diversion that they saw in the biopsy, you saw that biopsy that showed a very sick liver, and also then by doing this block of the bile acid absorption, now you see the liver getting better. It may be that what we saw with some of those cases, but still we don't have a large experience, is that actually cholestasis got better, and now your absorption improved, actually, rather than getting worse. But I think that some of that is that concern still around, because we don't have 100 to 120 patients that we have done this, and I think that's the main concern. But in my mind, I think is what is important is what is the quality of the life of your child. If your child is having really bad itching, I don't think you have to wait, because otherwise you will have to start considering transplant at some point, or doing something more aggressive. And if you can have this that could improve, at least give you a chance. Obviously, it's not perfect. Not everybody's going to get better. And you saw what happened with internal diversion. It was supposed to work for a long time and work for a short period of time, but then all of a sudden it's having a problem, because probably whatever was left, now it has the ability to absorb more bile acid. And that's part of the body also. The body tried to adapt with years, throughout the years, yeah.
because your body doesn't have the ability to readapt. It's directly, instead of basically sending the bile from the gallbladder through a piece of intestine back into the colon, where the system can, where your body can say, okay, you're going to bypass these absorption points. I'm just going to make them appear again down by the base where it enters the colon. With the external, from what I've been told, I guess you can confirm this, is that because it's such a direct diversion from the gallbladder to just the outside, you're not sending it through any other part of the body.
Then you have
the
less
circulation
of chances of what happened to this organ.
Yeah.
I guess in general there's more experience with external diversion in Alagille, and there's more with internal in some other diseases, progressive familial hepatic cholestasis. And Alagille, we have more experience with external, but I showed a paper, just 3 patients, but now external has been done in more patients than internal. I think there is in general more experience in Alagille with the external diversion. And you have that benefit, Alina was mentioned, if you take 4 ounces of bile out, it's not going to pass to any piece of small bowel that was left behind. And what happened throughout the years is your bowel is smart. If you left some ileum there, it's like when you have short bowel syndrome. It's like when you take a piece of the ileum or something happened, then the rest is going to try to do the function of whatever was taken out throughout the years. And then if some ileum was left at the end, now I will guess that the bile acid now went up, and the ileum that was left behind was not doing that function before, but now it's able to adapt. That's the risk with the internal diversion that you don't have with the external. With the external, you take that bile out, not going through anywhere. That's it.
It just goes directly.
It's more of the parts. It's a trade. No, you have external. You will have something here that, obviously is very visible. With internal, other than having a scar, that's it.
Mhm.
Mhm.
Yeah. It'll be taken down. We've actually already discussed that with the surgeons, and from what it's kind of a case by case, but for me, what they think it will either happen is either the stoma will get taken down at the same time as the transplant, because they'll remove my current gallbladder with my actual liver, and then the new liver will go in, and they'll either completely take it all down and do away with it then. The other option that they've talked about is that depending on what my internal anatomy looks like when they open it up, they have also said, there's a possibility that what we could do is simply separate the piece of jejunum from your gallbladder, tie it off, and leave it there, and let your body recover from the transplant, and then go in and simply take out that piece of intestine and close up where the stoma sits on the skin, and do it kind of in steps. But either way, I will lose the stoma because I won't need it at that point.
Yeah, that's not too much else to add there. It's very clear.
Yeah, it's kind of a case.
I mean, at the end of the day, you have right now, I don't know her bowel length, but an adult can have anything between 5 to 8 meters of small bowel. And you're talking probably about 10, 15, I don't know if it's specific of her surgery, but usually is a short segment. It's about 10 centimeters. Then you probably even take it out, and she won't have any major problem by losing that tiny amount of small bowel.
Yeah, I mean, they basically just went in, cut the jejunum, pulled the piece they wanted, sewed the other two ends back together, and then the jejunum now sits from that removed segment is the conduit from the gallbladder to the outside.
I'm sorry? It can also be closed. Like, let's say one day let's say she didn't have the need for transplant, and she say, I got tired of this, I don't want to have it closed, then you can just close it. Obviously, there's a risk of obviously itching will come back, and it sometimes comes back worse after you do that. That's what I heard from the people that have more experience doing this.
And for me, that's what they think would have happened, is based on my itching when I had it done. They said, if you ever did want this, just be very careful if you ever ask for this to be reverted, because chances are you will go back to itching, and it could either be what it is right now, or it could come back worse, and the chances of medication helping it, again, are slim to none, because unless, now, of course, with the trials, there could be something that would help, but at the time, they were like, if you want this taken out before they come up with a medication to help the itching that we know works for most patients, chances are you're going to be back to where you were right now. And so my plan is to keep it for as long as I can, barring a liver transplant, but otherwise I want to keep it. So.
Okay.
You good?
Well, thank you very much for your questions. Thank you.
And if you guys have any other questions, feel free to come and find me. I'm usually out manning the sales table out there, so just come and ask me if you want to.
Thank you. Thank you for doing this.